Keep it organized and go through systems. Welcome back to the new Nurse Guidebook YouTube channel. My name is Pierre LaFour, and if you're new to the channel, the purpose of this channel is to help new grad nurses live healthier, wealthier, more happy and fulfilling lives. So in our last video, we talked about how to create a report sheet for Handoff. Now, you might be asking yourself, how do I do Handoff and report? Well, I'm going to share with you what way has worked best for me and served me well in giving Handoff and report at shift change. A little bit of background behind what Handoff and report is, if you don't know, if you're a new graduate nurse, it's basically telling the oncoming nurse for night shift or day shift everything you know about the patient, what care they've received, their medical history, and what you anticipate coming down the road for the care they're receiving, and gives you a snapshot of different things to keep eyes on when you're taking care of your patient for that shift. No handoff's perfect, no nurse is perfect. Some people forget things, some people miss things. It's always good to do your due diligence and discount, double check, and know how to go through the chart and check information and get a better idea of your patient. But there is an art and a style and a certain level of skill and finesse with giving awesome and effective handoffs. So I'd like to share with you what I do for my handoffs and reports, and if there's anything you appreciate from it, then maybe you can incorporate it into your practice. So the first thing I like to do is I like to go down the line and I'll be like, okay, in bed space 6, we have John Johnson, 63-year-old male patient, no known allergies, he's a full code, he's a patient of Dr. Colby Jack Cheese. He came in on January the 18th. He received tricuspid valve repair, mitral valve repair, aortic root replacement, and a cabbage ×4. And with that cabbage, they got the graft sites from his legs, his SVG sites, and they also got one from his radial or his arm. He has a past medical history of hypertension, hyperlipidemia, coronary arterial disease. He had a heart attack back in 2018 that he received a stent for in his left ascending carotid, or left ascending coronary, and he has a past medical history of a CVA, cerebral vascular accident, and he has no deficits with that. So, boom, I've given you a little snapshot of the patient and the handoff now, and after that, I would tell the nurse, okay, now that we've touched on his history and what he's here for, the plan is to get him extubated this evening and have him up in the chair in the morning and sent down the step down either tomorrow or the next day, depending on how he responds. So now that we've touched on that, let's go through systems. And I tell that to the nurse, let's go through systems. Cardiac, heart rhythm. He's been sinus tachycardia. His heart rate's been beating fast from the 100s to the 120s. His MAP goals are 65 to 75. And he's been hypotensive, meaning his blood pressure is low. His MAP's totter between 65 and 60. He's on a drip for that. I'll touch that in the drips. And that way I'm not zigzagging back and forth between systems. I stay focused on the cardiac system still. His pulmonary artery pressures have been fine at 25/15, and his CVP has been 5 since I came on the shift, and it stayed at 5. His pulses are palpable, and he has a temporary pacemaker. The settings on that are DDD, and he's being A-paced at 10 milliamps of ventricular output, and his atrial output is 5 milliamps. Let's move on to respiratory. Respiratory-wise, he's on a ventilator right now. He's receiving 50% at 502. He has a PEEP of 5. His tidal volumes are 500, and he has a set respiratory. He's breathing actually on CPAP right now, so he doesn't have a set rate, and there's no other abnormalities in the respiratory department. Moving on to neuro, his pupils are perla. He follows commands appropriately. That means he squeezes your hands, it wiggles his toes. There's no deficit, he didn't throw a stroke, he doesn't have any sort of an aneurysm or new neurological development. He's able to nod his head appropriately to questions like, are you in discomfort right? Are you having some discomfort right now? Yes, I just had open heart surgery. In neuro, I also like to throw on any pain things related to that and what they do for pain control. Like, he has an order for fentanyl IV push every 1 hour, and I've been giving that, and that's been helping keep his pain under control. Moving on to GIGU, he has a Foley catheter in place. He's been putting out anywhere from 60 mLs to 100 mLs on average an hour. He has an OG tube in place that is hooked up to lower intermittent suction, putting out serosanguinous fluid. There is no GI bleed according to the providers, and he is NPO. Skin, he has a mid-sternal incision. He has 5 chest tubes. He has 3 right pleurals. He has a central chest tube, and he has a Jackson Pratt JP chest tube right here. And average chest tube output for all of them has been 10 mLs an hour across the board for all the chest tubes. Serosanguinous fluid hooked up to low intermittent suction with a water seal backup into the atrium. His butt looks good. He doesn't have any pressure injury related to that. Drips, he's on propofol to keep him sedated and comfortable while he's being ventilated. He's on 50 of propofol right now, and he is on Levophed to help with his blood pressure that I touched on earlier. And it seems that a Levophed at a rate of 6 is helping keep his blood pressure under control. If you're able to bring it down tonight, great. If not, then we'll take care of it on day shift. And then access in his right IJ, he has a swan line, and it is through an introducer, and it has a cordis. And then he also has a 18 gauge in the left forearm and a 20 gauge in the right forearm. Yeah, that is everything I know on this patient. There were no lab abnormalities. We can go through his arterial blood gas and show you the trend with that. And do you have any questions? One thing I used to do as a new nurse was butt in to report and ask my yearning questions. And I realized that that is very rude, and it's a big no-no in a lot of ways, because you're derailing the workflow of the nurse coming before you. Unless they're just a flat out bad nurse and they're not telling you important information like the date they came into the hospital, very rarely will I interrupt a report. It's a faux pas, and I know I hate it when people interrupt and butt in when I'm trying to go through the flow and hit all the systems, because chances are I'll answer the question that they have if they're just patient and wait and go through it. Typically when they butt in, I'll be like, yeah, here's the answer to that question. Where do they live? Yeah, it's a great question. We'll touch on that once I'm done getting through systems. If you could just give me a moment and kind of like steer the ship and steer the conversation. Be very polite, be very controlled and calm about it. But also don't butt in when somebody's giving a report. And that's just what I found from my personal experience. It's just a polite, good thing to do. And it helps handoff go by a lot more efficiently and more effectively and smoothly. So yeah, this is my method for giving report and crushing handoff. You know, some people will take 30 minutes for one patient. You can knock this out in about 5 to 10 minutes once you put in the reps and get more practice in it. I hope that this has helped you, and it served me well in my nursing experience so far. And if you enjoyed this and you got some value out of it, be sure to leave a like on the video. If there's something else you'd like me to make content on, please leave a comment. And if you know somebody else who would get value out of this video and learn something from it, don't hesitate to share it with everybody. But this has been Pierre LaFour signing off with the new Nurse Guidebook. I'll see you in the next one.